So could you start by just providing some background on the EMBRACA study and, including maybe the trial design and what we saw in the initial findings?
Sure. So the Embraca trial is the largest trial to date of single therapy PARP inhibitor. And in this case, it's Talazoparib, which is given just once daily, versus several physicians' choice of chemotherapy. There was a 2-to-1 randomization. This was an international study. And we had reported out the results and published them of the primary endpoint, which is progression free survival, of which there was an improvement with approximately a 3-month median progression free survival. And at that time, the overall survival data was immature. And at AACR, we presented the final overall survival data for the trial.
Perfect. And if you want to go right ahead and talk about what those findings were.
Sure. So in the final trial, in the final results of the trial that we presented at the AACR annual video conference, um, we showed that there was no statistically significant difference in overall survival of the talazoparib versus physician's choice chemotherapy. We also gave an update of the toxicities, which continued to be what we would have expected, with cytopenias being the most common and frequently anemia, which were managed with transfusion, dose delay, dose reduction. One patient had a diagnosis of AML that we reported during the initial progression-free survival data, and that patient had received capecitabine and not talazoparib. And in this update, we have an additional patient who was diagnosed with AML, and this patient was randomized to the talazoparib. A thing that unfortunately we see with breast cancer patients who've had a lot of anthracycline, platinum, cyclophosphamide, but no difference between the two arms. We also saw what persisted was that patients who were randomized to talazoparib had actually an improvement in quality of life and decreased time to deterioration, clinically meaningful deterioration compared to physician's choice chemotherapy. And then we also presented several other aspects. These were all exploratory. We hadn't started off with the trial with this because as trials happen, things change. And in fact, during the trial of EMBRACA, PARP inhibitors became commercially available. And so there was 40 to 50% of patients received further platinum on the other side of this trial. And a large proportion, 30 to 40%, received PARP in the patients who didn't receive talazoparib. So, we tried to look in ways that we could, understanding it was all exploratory, to see, and there was a potential that might have affected, as we see in most trials with metastatic patients with overall survival. The good news for our patients is that we have more options for them. They are living longer, and we have more to offer them. It is hard in some cases to tease out exactly which part of their therapy is adding to that overall survival. Always a complicated issue with metastatic cancer trials. And I would say that for metastatic cancer trials, especially as we move into some more toxic therapies being evaluated that I think are important, we need to make sure, in my opinion, that we continue to look at patient-reported outcomes for patients in these metastatic trials, because this is an important aspect for our patients when we're counseling them, makes them feel better, then that's important, versus if we had something that might improve progression-free survival for a month, but we make them miserable and bedbound. These are all things that we need to be able to have this information to discuss with our patients when we're providing the different options.
Absolutely, very good points. So you touched on this, I think, but what would you say the implications of these data are specifically, and in terms of interpreting them? How do you think talazoparib will kind of fit into the treatment landscape going forward?
I really think that this data just continues what we knew from the primary trial, that it did meet its primary endpoint. PARP inhibitors are here to stay for patients with BRCA mutations, not only because it does improve progression-free survival, the improved quality of life, the oral option, I think is really intriguing for a lot of patients. They tend to work it just as quickly as chemotherapy. So the idea of someone having a big burden of disease, we need to hit them with two types of chemo, not so much. We've had dramatic responses. Um, the I think that in the future, we're looking at some combinations that hoping to gain some longer legs on these therapies for how long people benefit from them. And also, how do we do combinations or otherwise identify patients outside of the germline BRCA mutation carriers that could benefit? At this point, still germline BRCA1, 2 mutation carriers, even from the correlatives that we presented, are really those most likely to benefit at this point. I think we're going to see other genes like PALB2 start to be grouped into there as we are identifying more patients with PALB2, but that all mutations in these inherited DNA damage repair genes are not the same as far as response. And I think there's some excellent studies going on right now, really trying to tease that out so that we can provide that information to our patients.
Great. Are there any studies on the horizon that look particularly interesting that you want to highlight?
Sure. So when we're looking at if we're keeping discussing about PARP inhibitors, when I'm thinking about those trials on the horizon, I am always intrigued by the PARP inhibitor and the IO or the immunotherapy. I think I get asked often, well, should you do PARP first for metastatic cancer or should you do chemo and IO? And I don't think that you have to have such a binary choice. It's not either or. It's really you're going to see both of those therapies. I think that in both the PARP inhibitor trials, there's an idea that maybe the sooner you give it, the better. We certainly see that when we give immunotherapy combinations, the sooner you give it, the better. But I think that when you're thinking about a PARP inhibitor, it's really intriguing because we are seeing some increase in some of the markers needed to be positive, like PD-L1, in response to PARP inhibitors. And so work like that from Susan Domchek, the Mediola trial, the Tapaccio trial, I think are really showing us that not only the combination, but also how we sequence may be important. I think that we're going to see other DNA damage repair pathway drugs come through, and how we combine those with PARP, and how we leverage blocking PARP in people who don't have a germline BRCA. I'm very excited about some of those trials. And lastly, I'm very excited about the Olympiad trial. This is the adjuvant PARP inhibitor trial for patients with residual high-risk disease who go on to receive a PARP inhibitor. And I think that data, as well as data ongoing in the preoperative space, will bring PARP inhibitors to earlier stage patients.
Excellent. Is there anything else from either the trial, from practice, that you'd like to add that I didn't ask you?
No?
Okay, that's perfect then. Thank you so much for taking the time out of your busy schedule.
Thank you.
Thank you. Have a great day.
You too. Bye-bye.
Bye-bye.